Hi, thank you so much for joining us. We'll be getting underway in 2 minutes. Leave my awful French behind and say thank you. My name is Joel Harden. I'm the member of Provincial Parliament for Ottawa Centre. It is a wonderful pleasure to be working with all of the neighbors in this room, in particular neighbors who are engaged in youth mental health this afternoon. Want to begin in a good way by acknowledging that this particular space we're in, 464 Metcalf, ground floor boardroom of this amazing building, the Beaver Barracks building owned by the Centertown Citizens Ottawa Corporation. My landlord, I think they're great. But this building's on the unceded and unsurrendered territory of the Algonquin and Anishinaabe peoples. And I say that at the beginning of every meeting, not just as a box ticking exercise. I think as we acknowledge the path we're on as a country towards reconciliation. That's about making choices intentionally to make our community safer, more prosperous, give people opportunities. And when I think about youth mental health, that's what we're doing. So I would like to think that it's very much in the spirit of reconciliation. So I want to thank Algonquin and Anishinaabe peoples for that teaching and many, many others. We, just so people have a sense of what to expect this afternoon, Ottawa, I have a lot of Ottawa hubris from here. Ottawa is blessed with people with great expertise in mental health. And the reason this mental health forum is happening is because neighbors contacted us and said, Joel, we need to talk about youth mental health services, clinical services available. And we also need to talk about mental health opportunities for youth in the city of Ottawa. So the first hour that we're going to have this afternoon is going to talk more on the clinical side. You're going to hear a presentation from our friends at One Call, One Click. And they're going to go over services that have been built up intentionally to be there for youth in their moment of crisis. And that's important. The other thing we're going to hear from is our friend, Dr. Sherry Mayman from Anchor Psychological Services, who joins us via the Zoom and this wonderful little tool we've learned called the OWL. So Sherry can actually see all of you. If you look at that little box up there, there's a panoramic camera down there. So it's a way to bring Zoom into the room, as it's been explained to me. So Sherry's going to talk to us a little bit after the One Call, One Click presentation of what running a private psychological practice has been like, what some of the challenges have been for Anchor Psychological Services and trying to promote mental health in our community. Then there's time up until 5 o'clock for some question and answers. And I know people are coming to this room with a lot of curiosity, a lot of questions, a lot of concerns. So we're going to have time for that. And then at 5 o'clock or roughly afterwards, there's going to be an opportunity for us to mix and mingle. A number of people are in this room, and a lot of you don't think of yourselves as mental health providers. You look at Master John Dubras from Dubras Martial Arts here. I think about the Ottawa School of Art. We're also here this afternoon. There are many ways, Volunteer Ottawa back there. There are many ways in which young people plug into things to enhance their mental health services we have that we want people to know about. So that's the latter half of our afternoon. It's us taking advantage of the resources we have. Okay. So with that, I'm going to invite One Call, One Click to come on up and talk a little bit about this amazing program that's been built over time. And thank you so much for being with us.
Awesome, thank you. Hi, everyone. My name is Cindy Dawson. I'm going to sit down to make this a little less formal. I'm really excited to be here today just to talk to you about an initiative that launched during the pandemic, which I think is pretty amazing, because I think the work, as I was working previously in a role of an intake worker at CHEO, and oftentimes we were finding young people get referred to our services, and we'd send a letter back to the doctor and say, call Rita Wood or call YSB, these are where you should go, and then the doctor would feed that back to the client. And then it becomes on the family member to try and figure out, where was that phone number? Where do I go? I can't remember what I'm supposed to. And for example, I might have said, go to YSB, and it actually was more like Crossroads. So it might not have been the right place. So as a community, we came together and said, we got a problem here that people don't know where to go for services. They're knocking on multiple doors because they're desperate for help. Their child's in crisis or their youth's in crisis, and they really need some support. So we sat at the table with, core service providers, inclusive of some of our partners here, like Rita Wood and YSB and Crossroads and Valoris and Phoenix Center, and multiple providers, Le Cap for the francophone population. And we had some family and youth advisors as well to kind of say to us, what is it you need? So we all work together to kind of say, okay, we need to know regional data. We need to know how many kids are actually looking for services in this region, because we know that Crossroads has a wait list and CHEO has a wait list, but we don't know how many kids that is. It could be half of that number, or it could be twice that number. It really isn't streamlined. So we can't advocate for needing more services if we don't know the actual numbers. We also don't know what kind of programming we should be offering, because we don't know what the primary problems are. Maybe it's anxiety. We think maybe eating disorders is a big deal, but then how do we statistically prove that? So that's where we have a very robust evaluation team of 2 people. but they're very good. And they look at all the data that we capture at one call, one click. And then we feed that back to the providers to say, these are the presenting problems we're seeing in this region. And this is how we should be organizing our programming. We've partnered with Anchor and they've been offering, groups for families that we advertise out to our people that call our line to say, if your child needs help and you have the ability to go private, Anchor is offering these education sessions for families and certain interventions for young people. So that part made it really important for us to create this program that, although the backbone is kind of embedded in CHEO, as far as I'm employed at CHEO, our intake workers are physically working in all of our community agencies. And we meet every single day to talk about cases and where do we go? Where do you think we should send this young person? Because I'm not really sure. And so we build capacity within a consistent intake across the region. And we all share consistent resources. So if you talk to somebody that's, Ashley from Crossroads, and she's going to recommend something, it's going to be similar things that she's recommending as the CHEO intake worker working out of one call, one click. And the experience will be the same. Same screening tools, same data is captured, and then we match them to services. The other good thing is I've heard people say to me, oh, no, like you don't understand, this patient is way too sick for one call, one click, like they need urgent services. Well, we have embedded in this partnership is the partnership with psychiatry and psychology and the outpatient mental health clinic at CHEO. So anything that comes through one call, one click, we have pathways built in behind that allow people to be connected to an urgent psychiatric assessment if that's what's deemed necessary. Our goals are to try and avoid people going to emerge because they're desperate and want to get help. And then we have those pathways built. So the process is someone would call the phone line. It's the YSB crisis line. You dial 1 if you're in crisis, or 2 if you want to do an intake. And then the intake worker would do your live intake, and then they would say, match you to, I want to say Rita Wood because they're sitting right there, and match you to Rita Wood. So it's nothing more for you to do. Rita Wood then gives you a call and says, hey, we got a referral. We want to book you in for an appointment. Come on in. And that's how that works. The options are also self-schedule. So you can go on the website and you can say, oh, I like the name Griffin. I'm going to go with Griffin for today. And I'm going to pick this day, this time. And you have the ability to do it in French or in English. And you can pick whatever appointment time works best for you and schedule it in. And you have a choice of doing it over the phone if that's more comfortable, or you can do it by Zoom if the face-to-face thing works better for you. So it allows those options of flexibility. We also have the possibility for translation or interpretation during the intake. So we wouldn't do it for French or English, but for other languages, we would offer that service. And it's just a process of the referral form coming in and then us calling you because we have to set up the interpreter. So it adds just another element to it. But we're definitely we have a robust interpretation service that helps support that. For physicians, I've met a few that are in here today. We accept referrals through Ocean. Pretty much we accept referrals from anybody. Right now we get them from fax, we get them from Ocean. The nice thing about Ocean is that it feeds the information right back to the doctor. So they know right away when we book an intake appointment. But any referrals that we get, we feed back to the referral source. So if your family doctor is sending a referral in, we're responding to them saying, hey, got your referral for Johnny. Johnny's going to be getting services at YSB. Here's the results of the screeners that we've done. And then that's basically how it works. So our website has a few self-serve options. I'm not going to say they're robust yet. We're still in the work of rebranding. We've partnered with ementalhealth.ca to kind of pull some of their info sheets out. They've done some amazing work. And then we're rebranding it to our name. But yeah, lots of really exciting things happening and lots of pathways being built. We've more recently partnered with some of the community health centers to say, hey, we want to share information. Our big thing is we don't want families to have to retell their story if they don't want to. Some people want to retell their story. So we send the referral information over so that when the first person is coming to meet with you, they'll say, hey, I'm noticing that these are your goals within the intake. And how do you want to start working on these? As opposed to, okay, why are you here? Let's start all over again. So those are our goals for the program, and our goal is to make it easy. The other thing is too, is we go up to the age of 21, and 21 also kind of partners over with Access MHA because they do 16 and end of life. So what we do is we would just send the information back and forth. If they get a young person, they send it to us. And the key is not handing it back to you and making you figure it out.
Okay. So just so I'm clear, as we segue to Dr. Naiman in a moment, the service has been set up is one call, one click, and then the system allows the youth and the family to navigate the service.
Yep. Well, we navigate behind the scenes and the services call the family.
Okay.
So I'm not telling them to call somewhere. They call this place and then the navigation happens on our end.
Okay.
And sometimes they're head scratching moments, but that's why we have a great team that we collaborate with, so.
Well, thank you, thank you. We're gonna get into discussion in a moment, and this is gonna look weird because I'm gonna look at the owl, talk to Dr. Naiman, but Dr. Naiman, over to you. Your perspective, we're talking about youth mental health this afternoon, what you're seeing in Anchor Psychological Services. We really also just want to begin by appreciating the fact that you made time for this afternoon. Over to you.
Of course, thanks for having me. It's great to be with you, Joel, and Cindy, who I used to work with over at CHEO. And this owl thing is letting me realize how big I am in this room in front of all of you, which is a little bit intimidating. So I'm Sherry Naiman. I'm a clinical psychologist and I'm co-director of Anchor Psychological Services, which is a private practice here in Ottawa. We currently are a team of about 14, and that includes psychologists and dietitians and a learning and mental health consultant. Our services are fee for service, and we recognize that that is not accessible for everyone. But we have also seen a huge rise in the demand of our services. So when I entered private practice 10 years ago, because Anchor was established 10 years ago, we expected a number of things. We expected that maybe we would have to look for clients. And we also expected, perhaps foolishly, that some of the clients that we were going to be seeing were going to be more mild than the clients that I used to see when I was working at CHEO as a staff psychologist in the eating disorders program. And all of those myths were very quickly busted when we realized that because of the lack of access to mental health care, many of the clients that we were seeing were as severe as those that we were seeing in the tertiary care system at CHEO. And we very quickly got to a place where the demand for our services outstripped our services. And this has been an ongoing process. We service children, youth, and families as our primary population. And then we also service adults for individual therapy. We have a very strong family focus at Anchor. So there is no one that comes in as a youth where we would expect, unless it's extreme circumstances, that families would not also be involved. So we've been dealing with this really high demand, which, is unusual for private practice work, but certainly by the time the pandemic hit in 2020, we were dealing with some unmanageable wait lists. And we actually had to close our wait list over COVID because it wasn't even a real wait list anymore. When we were telling people it was going to be 2 years to see our psychologists, and please don't wait, we were really recognizing what a crisis we were in. We've managed to clear out our wait lists. But we're still seeing the effects of the pandemic on children, youth, and families. We've definitely seen some different categories in terms of youth mental health. There were some where referrals came to us and things were in crisis around pandemic issues, and just return to life really resolved issues for some of those children and youth. And then we've seen some that are continuing to struggle with the after effects of the pandemic, and also those that were struggling before that we have continued to follow. So that's what we're currently seeing.
So, Sher, if you don't mind me asking, everything I'm hearing leading up to today, and what you're telling me leads me to believe that this has for a long time been the unrecognized pandemic. Like this is how many waves did we go through in the COVID pandemic? One almost forgets, right? But I guess the question I would ask, because you work both in the public system and now in your own practice, what do you think the system needs to accomplish beyond, setting up the emergency options that we have and enhancing them to get the kind of support that you're offering people out to more neighbors who need the help?
So interestingly, I think there was a child and youth mental health pandemic before the pandemic, because as we know, mental health care is the orphan of the healthcare system, and child and youth mental health care is the orphan of the health system. So we know that only about 1 in 5 children and youth who struggle with mental health difficulties are actually getting treatment for mental health difficulties. And what we need really to meet the need of children, youth, and families is a complete overhaul of both the public system and also the education system. So if we take people like me, I'm a psychologist, a clinical psychologist, and in Ontario, that means you have a PhD requirement. If we look at the model of training for psychologists currently, a class of psychologists that graduates is about 9 people in a graduating year. So nine psychologists per year are not going to meet the demand. It's like meeting a tsunami with, trying to hold back a wave. So we need absolutely more funding for more training for mental health care professionals, and even possibly a different way of training mental health care professionals. That's at the psychology level. Obviously, there's a huge number of people who take care of the mental health of children, youth, and families, and that includes registered psychotherapists and social workers. It includes nurses. There's physicians who do psychotherapy. Psychologists have some unique roles, especially in the assessment and diagnosis realm, that is not available to some of those other mental health care professionals. But what we really need is more people, more training, more bodies. And what we experienced, certainly before the pandemic, was that even in private practice, the number of people treating children and youth is smaller than those treating adults. So really expanding training programs that specialize in children and youth. And then my personal bias, because I'm a very family-focused psychologist, is that the system needs to recognize the important role of caregivers, of family members, and we need to harness the power of parents. There's still a lot of parts of the system that exclude people in mental health care, exclude family members, and family members are the ones living with generally the youth that are struggling, and they are in the best position to advocate. They are in the best position to learn a core set of skills to help their youth. So to the community members out there today, especially parents and guardians and people who love youth, I would say that one of the ways of accessing help is learning as much as you can about what your youth is struggling with, learning some core skills about how to support them. That's something that we do at Anchor. We offer 3 caregiver workshops a year where we teach practical skills to support your youth and actually adult children emotionally and practically with the things that they struggle with. But I think the entire system needs to recognize the power of families as an additional piece, and also really listening to what the families know and are demanding.
So Cindy, thinking about what Sherry just said, and we'll get to discussion in just a second. Somebody wrote to me as we were leading up to today and made the case that the system that we have, this, I'm just going to quote from the email, forces children to get very sick before we give them mental health care. This isn't rational, it's not humane, was basically saying that my kids fallen through the cracks to the point where they're now in crisis but didn't need to be. Yeah. Is this a story that you encounter as you try to help people through One Call, One Click?
Yeah, I would say I would have encountered it more when I was working as a centralized intake worker at CHEO. It's that idea of, you don't meet criteria to be on the wait list for
Right.
hospital-based services, and that's where that helpless feeling felt like. I feel like with the partnerships and the pathways we now have developed with the community providers, it allows us to match the community health centers when we know that there's early signs of things going on, and that we want to make sure that those services are being utilized when they are appropriate, versus, trying to force someone onto a wait list for hospital-based services when we know that's multiple months. The one thing about the system that, Sherry alluded to as well, is that the demand is just so high for what is available and the resources, and you look at community providers struggling with staffing issues because of the lack of training and the lack of people coming out of school in this field, or people leaving this field because it became too difficult.
Right.
So really making sure that we're looking after the people that are looking after them, but also the piece of making sure that we actually have adequate resources available across the different step levels of care, right? So just because you're struggling with a low mood doesn't mean you need to see a psychologist and get a diagnosis of an anxiety disorder. It means that someone needs to talk to you about what's going on and maybe teach you some coping strategies. So you don't have to sit and wait for 8 months on a wait list and then get picked up to find out that you probably should have just started some coping strategies over here. So that's where the crisis happens, is when they're waiting over here. So that's the nice thing I feel about the system that feels good right now, is those pathways developed with urgent hospital services. So you've got somebody who's really struggling and they can't wait. They need to see somebody. Don't go and sit and emerge. We have pathways built to actually see a psychiatrist tomorrow or the next day if you are in that level of need. And if you're not, then that's why we reached out to the community health centers and said, hey, we really need a pathway here, because we're seeing the lower acuity kids and we want to pick them up now. And that's where they're like, oh yeah, we've got this. This is our wheelhouse. We have resources and we have, activities planned. And these are the things that we want these kids to be doing. So it's us understanding when does it make sense to go where, and understanding that across the system so that we are maximizing all the resources that are available for young people.
Okay, and as was mentioned, we're gonna throw it up for discussion now, but we've got people here in this room who are part of the referral network. We've got Youth Services Bureau in this room. We've got Rita Wood in this room. We've got Cleo in this room. We've got Jewish Family Services in this room. So we've got people here who are part of this access team that's been set up. It's almost like a rapid response referral system. Okay.
Yeah, it's a good part. It's a partnership, and that's where it's really important, is that, we have this wheel of people and it couldn't keep going around unless you had all the right people as part of your wheel, right? Like, so it's really important that we just, our partners are so important. And even you talk about Cleo, and Cleo is one thing that I don't know that was utilized as much as it should have been before we launched and had Cleo the person that is our co-chair of our steering committee is as a Cleo staff. And, she's always saying to us, like, okay, family peer support. So we try to break down the ways that we can make the match to that service seamlessly, again, the same way we would another partner, so that they get the information that they need to be able to reach out to that parent and say, I understand you called one call, one click, how can we help?
I know there must be questions. I'm just looking, Dr. Neely, nice to see you here, by the way.
So with my family doctor, I would say all the organizations, we run all on like we use that all the time, we do that for our patients and then send it to the would. What we need, and Joel, this is your job, is we need government funding for more publicly funded psychology and mental health care, because most of my patients can't afford to go spend $200 or more an hour for private psychologists. Most of my patients, and that's true for across the province. Most people, if they have found a doctor, will have a needed primary mental health care provider because we're covered by OPA. But then we're at our limit of what we can do, and we need our patients to be able to afford to go to a psychologist who don't have private psychology coverage for the work. And we need to know that it isn't only when the patient's suicidal that we can
Right.
yeah.
Right.
Or you know, get them what they need. So that in my family medicine path, in my trustee, I think also the reason that we assembled this is that we're seeing students who are struggling and they're not necessarily getting what they need because they don't know where to go. So part of it was to make sure that we get the information tested through the Board of Education to all of these people, including the teachers, because that is usually the person that students trust, right? But making sure that everybody knows about on clinic and also some mechanism for flagging when somebody isn't doing well. Like I know I have patients who have missed all the grade numbers, all the grade and because of mental health, they fall through the cracks and they're not going to get the help through the schools and they're not going to get the help if they don't have private psychology. So we need your help getting more funding through the province for mental health care. We need the board to be working hard on making sure that everybody knows what resources are there and somebody's watching for which student is volunteering.
Thanks. I also want to acknowledge Lyra Evans, who's the chair of the Ottawa Carl District School Boards here in the room. And I think someone here is Peter Sims from, thank you, Peter, to speak. And sorry, I'll contact my dad. Thank you very much, all of you, for being here. Cindy, Sherry, do you have any, like the notion of that, like learning in our city to quickly refer people to one call, one click? Is this part of what we have to do after today?
I think the biggest thing is being able to flag something's going on and have a conversation with somebody about it, regardless of how severe the problem is.
Okay.
Not waiting until it gets so bad that we're thinking, holy Moses, it's that really working on trying to reduce that stigma.
Right.
For substance use health, for addictions, for mental health,
Yes.
all of those pieces, those are really important. I think about Rita Wood and the work that they do, even for kids that are just starting to have, and they think they might have a problem. If they're talking about they might have a problem, the problem probably is bigger than what they're actually saying. So that's where it's really important. And that's why Rita Wood supports us with doing referrals for all types of kids that come in so that we are capturing all the ones that need help. Because often substance use is underreported.
Absolutely. Share anything you want to add?
Yeah, I think there's a number of mental health issues that are underreported for a variety of reasons. And I also think that it becomes confusing when we look at periods of development. Sometimes it can become confusing for not just parents and other family members, but healthcare practitioners around what is normal adolescent development, what is problematic. And I always really encourage people to err on the side of caution. And, you know, if you have a concern about a patient of yours, a client of yours, a child of yours, try to attend to it, because the earlier that you attend to it, the better. I also wanted to comment about the idea of publicly funded mental health care. And this really, I was at a talk yesterday actually about sort of the future of psychology, and we were discussing how, you know, the notion of us having a healthcare system is false, because mental health is part of health. And what we actually have is a very splintered care system where largely mental health is not funded by the system. And I would say that the majority of psychologists would support being publicly funded, assuming appropriate compensation for our work, understanding that, you know, people like me who run a private practice, I am a healthcare practitioner, and I'm also now a business person who has a staff, who has expenses, and it needs to make sense. And I would say in terms of accessibility and my commitment and belief in accessibility, I would say the majority of psychologists would support being in a public system with adequate and appropriate compensation.
Yeah, we'll get some of those big provincial pension funds to open up to you and your employees. We'll find a way to make it work. Dreaming now. Okay, there must be other questions. Yeah, go ahead.
Okay, question, so many comments. One of my questions is about one click. We'll call it click. I know it's been fairly familiar to physicians. It is not something that's been familiar to the general public to the same degree, and particularly to schools. I'm wondering if there are any plans, or if that's something that would be worthwhile pursuing in terms of, you know, the school board, because there are representatives in the school board here, and one of the getting that information into the schools, because it does sound like it's a good resource, but it hasn't been made fairly familiar, I think, more to the general public, so much as just in the physician's office. So that's kind of one question, one comment, and one question is, one of the things I'm co-chair of the school council on a fairly large school, and one of the things I'm seeing is that kids are being able to access interim crisis attention, like counseling for the immediate crisis. But they can't then access the treatment that they have. And so they just, you know, they might be okay for a little while, and they'll fall back into crisis for a little while, and that's not a sustainable cycle for anyone. And so I'm wondering, in terms of one care, whether or not services that are referred to is about referring the long term or just dealing with the immediate crisis.
So the first point, excellent,
Can I just, Joel, could you just repeat the question?
Oh, sorry.
Yeah, okay, so on the one hand, what we were just hearing about by way, are we doing a good enough job promoting one call, one click, if I'm understanding correctly? And then there was also concern that a lot of youth in the school environment are getting immediate access to counseling help or help in the middle of a crisis, but then people slip back because of the absence of that more comprehensive care, if I'm understanding correctly. Thanks.
yeah, so your first point is an excellent one around the schools and how important it is, and we totally agree that it is really important, and we have tried to advertise it in schools. We printed up a bunch of these bookmarks and had we have 14 nurses they're called mental health and addictions nurses that were recently allocated from the home and community care into one call, one click. And those nurses are boots on the ground in the schools. And so they're trying to put up posters and hand out bookmarks and trying to promote it. We launched social media campaign under Twitter, Instagram, Facebook. We were going to do TikTok, but we opted not to, thankfully now. But so we are looking for ways to get it out more and trying to figure that. So open to ideas. We definitely will have close partnerships with school boards. We have mental health leads from every school board that work closely with the mental health and addictions nurses, and also work closely with us as a result of that. So looking for lots of opportunities to bring it out into the schools more, and looking at mental health weeks and trying to buy swag and all that stuff to try and actually hand it out so that kids can talk about it. The other thing that you commented about is the short-term versus, longer-term counseling. There is no secret that although we're making access to services easier by doing one call, one click, the system behind it hasn't changed. So one call, one click isn't a clinical treatment delivery. It's a navigation and goal setting program. So once we match to our partner agency, which might be CHIO, or it might be YSB, or it might be Crossroads, that system that they have there in place has not changed. And that's where you're feeling the, Counseling Connect has single sessions where you can go somebody with one problem at a time. So these single session things are popping up. It's that getting past brief services, and then you have an 8-month wait or a 9-month wait. And so that's where we need to put more resources to help support. Our job is navigating them to the services, and then the back end really needs some more resources embedded within it.
Just before going to another question, so people know what we're hoping to do with this afternoon session, our office is going to be doing a report based upon what we heard today. And our hope is that we have a decent relationship with the Associate Minister of Mental Health and Addictions, Michael Topolo, in the current provincial government. We intend to let him know what Ottawa has been doing. What Ottawa has been doing to centralize the intake, what people have heard in private practice, and then what we're hearing in the community. Once we have our turn this afternoon and we visit our friends like The Door or Pleo or Ottawa School of Art or Duvers Karate, you circulate that or volunteer Ottawa back there who happens to know everybody, connected to lots of opportunities. We want the Ontario government to know that, I have a lot of Ottawa hubris. We're proud of what we're doing here, but we need it to be well funded. And every community deserves to have services like we have, even though we know we need to improve them.
Just one more point to that, though, is also recognizing that children are different than adults. They're not just small adults, right? So the pediatric system needs to look different. So, looking at the funding that goes out and say mental health as a bundle, we need to look at kids. We need to look at kids differently and look at kids involved, more of the caregivers. Their developmental milestones are different. They're changing as they go. These are really important years, and these are our future. So that's where we need to look at customizing a system that works for them and not trying to fit them into our current system.
Fair enough.
Thanks. I just wanted to talk a little bit about the school board and some of the things that we noticed as well. The question around schools doing a better job around sharing access to. When you come up with like.
Yeah. The online audience will appreciate it, Peter, for standing right here. Go ahead.
So just in terms of in response to the school board, we are currently renewing our 3-year mental health strategy. We have a youth advisory committee that is working with our mental health lead, and we're hearing from students as well. When we have a situation, we don't know where to turn. Where you mentioned all the different social media outreach you've done, and we thought we were doing a good job getting things out to kids. But we're hearing from kids, we still don't know where to go. We're also hearing from adults in the schools. We don't know where to send kids either. So part of our next 3-year mental health strategy will be doubling down on our efforts to ensure that kids know where to turn and where to offer to a friend who might be struggling. This is where you can turn. You're exactly right. The infrastructure behind us isn't exactly robust at the current time. But taking that first step, reaching out to get some support, I think is an important first step. So we are going to be working to address that and coming up with some ideas. Hopefully, we do work very closely with One Call, One Click through our mental health lead, but trying to address that in a more robust way to kind of move the needle a little bit.
Thanks, Peter. Question here, go ahead. Yeah.
Sorry, I'm getting up because I'm used to this anyway. I'm an instructor at the college, and I wanted to ask about the post-secondary institutions, and particularly about the international students who are leaving their country. They're coming to a place that they're being prepared to set up. But I have seen in my class people who are struggling, and I wanted to know what we're doing. I have another question, if I can come back if you don't mind afterwards, to do with statistics and some other aspects.
So for our friends out in the Zoom world, the question was about the post-secondary environment and services available to students, particularly international students. And Sherry or Cindy, do you have thoughts?
I can speak a little bit to that. I mean, most universities do have counseling services, and there's quite a bit of variety from university to university. Sometimes graduate students in clinical psychology programs are part of those clinics, and then most of them also have, counselors, social workers, registered psychotherapists available to students. But like everywhere else, demand outstrips resources in university mental health care. And certainly we have international students in a very vulnerable place who often can't access some of this care in other places because of, OHIP cards, insurance, etc. So for them, it really is through student services that they would be getting it. And many universities are on a very short-term crisis management type of service at this time. And I think there's so much that can be done preventatively so that students don't get to crisis, that are more inexpensive options where it's not always one-to-one therapy. But I think we need to do a much better job of preparing, orienting, providing a sense of community for students who often feel isolated, who are experiencing a huge transition. And we know that the most vulnerable times for youth are during transition times. And that's transition to high school, transition to university are the peak times of stress, anxiety, and other mental health crises. So universities need to do a better job of addressing that more preventatively. And then absolutely student services need to be way, way deeper. And I wanted to add, just in terms of all of the areas where we're talking about there not being enough resources, at Anchor, my partner and I are very, very lucky to be involved in training mental health care professionals all over the city. And so my YSB people out there, shout out to you. And Crossroads and Rita Wood, all of whom we've been partnered with in the past. What I do want to say is there is tremendous quality in terms of care. The people working in these agencies are phenomenal. And when you can get access, the care is fantastic. But we are lacking absolutely the numbers. And then also considering the working conditions that people in community agencies are struggling with, where compensation is often not adequate, and the pressure to do more with less, or to do short-term work when they know full well that they need to be doing longer-term work, is something that a lot of community mental health care workers are having to deal with. And it does cause them to go into the private domain in huge numbers because they don't feel those same pressures.
Fair enough, fair enough. Other questions? Yeah, in the back, yeah.
Thank you. Well, I will present myself, perhaps it will give a better background where my question comes from, right? I'm Camilo Corral. I work with international organizations for humanitarian projects. I have been working for 20 years already, designing and formulating implementing mental health psychosocial support programs for people that have lived career crisis, so actually, so my point is, from that experience, I have navigated and explored a lot what is the approaches that are implemented here in Canada in general, and specifically in Ontario, in terms of mental health, right? And what I can realize is there is always this perspective, one-to-one, a very clinical perspective, and also a perspective essentially led by the biomedical conception of mental health. It means very linked to pathology, right? So my question is, there are a lot of evidence all around the world about preventative programs on mental health that actually have been implemented successfully in different parts of the world, because it has also to reduce the demand of psychologists, for example, or social workers, because those approaches cover and extend a large group of population, right? So my question is, what is the state of that discussion here, like conceptual, professional, technical discussion here in Ottawa, perhaps, about implementing other kind of approaches that are not necessarily led by this biomedical perspective? Thank you.
And if I understand correctly for the Zoom audience, so the question was reflecting on the Canadian experience from here, but also from elsewhere. Are we relying on, as you mentioned, biomedical model? I would say psychotherapy, psychology, psychiatry model. And I have heard discussion, Sherry, Cindy, about cognitive behavioral therapy skills extended to people in other professions, school boards, faith organizations, community organizations, just so people in the Zoom are aware of the question. Over to you.
Sherry, do you want to take that one?
Yeah, as part of your question, I heard some really interesting pieces, right? Talking about prevention, talking about, looking at mental health outside of the structures that we have them here, certainly in North America. And large, it's very interesting. When I was thinking about becoming a psychologist, my initial interest was looking at developing large-scale prevention programs. And I looked around at the universities in Canada, and there wasn't a single program to support the learning goals that I had. And yet in the United States, there were several programs that were focused on community psychology, prevention-based programs. And I'm happy that I became a clinical psychologist, but I was very interested in exactly what you're saying. And I think Canada really needs to get more innovative in terms of how they use people like me, but other kinds of practitioners in developing programs like this. And then on a more personal level, and I think this fits with lots of cultures, we need to harness families, and we need to help families help their loved ones. And so we need to really teach families skills that are going to change the culture of families and make mental health things that we can talk about, make emotions things that we can talk about. So I think there's lots of different ways other than one-to-one therapy. And, even group-based programs, group therapy, interpersonal kinds of therapy, we know are so important because of reducing isolation and reducing the sense of people being alone in these things. In terms of CBT, look, CBT is great. I really want people to know that CBT is not the only form of therapy that is highly effective. I know that there's a large evidence base, but there's a large evidence base against a number of modalities, including DBT, including emotion-focused therapy. I know that I often get referrals from doctors that this client needs CBT. And often that client does not need CBT. This client needs a variety of other approaches or an integrative approach. But I certainly believe that lots of important skills can be handed over to teachers, to occupational therapists, to physical therapists, to social workers already have them, certainly family docs, in a world where they would have time to deliver these skills, which is not our current world. That absolutely there's many of these skills that can be handed out and more people can be skilled in them and in delivering them. And schools would be a great place to really teach kids about emotion and coping with emotion from the beginning.
So just as we throw it up to questions, it's something to riff off of what you just said, Sherry. We had a smaller group that helped us plan this meeting a couple of weeks ago. And one of the people who came to that was an OCDSB outdoor educator, somebody who takes kids out into the wilderness. And that person's comment as we thought about planning for today was, I didn't expect to be in therapy, but youth after youth who went on these really transformative experiences, all of the stories came out. And that educator felt woefully unprepared for that moment. Like went with it and just tried to keep the line of communication open, but would benefit not necessarily from cognitive behavioral therapy, as you're saying, Sherry, but some kind of training on how to work with emotions, how we deal with emotions, how we help people. Is that a similar analog for what you're talking about, Sherry, like broadening?
Absolutely. I think we need to empower people who come into contact with children and youth with better skills. Coaches would be another avenue. Coaching, sports involvement. I look at actually the number of children and youth in my practice who have had very difficult experiences with coaches, who because they don't have those skills and because, coaches aren't brought on to coach because they are great at understanding child and youth development and feelings. They're usually brought on to coaching because they have athletic skill and athletic knowledge. But we're increasingly seeing the stresses experienced by kids in sports and in sports involvement, and coaches need to be empowered with a whole set of skills to understand where kids are at these days, to recognize warning signs. I focus a lot on eating disorders. I can tell you that's a domain that coaches need to learn a lot more about. So people that are in contact with children and youth need to be prepared to deal with child and youth mental health at varying degrees of expertise, obviously.
I bet if we talk to art educators who are here too, we'd hear a lot about emotions that surface in the process of creation too, I bet.
Well, our school was really lucky. We had, forget the name of it, you have first aid training, but this was mental health first aid training. And we all took a course, the instructors and the admin. And we really found it helpful because we come up against that when we're teaching art and in art classes. So that was something that was helpful and that we were proactive on, and it's out there for people to access.
Do you mind me asking, not to put you on the spot, but in the course of somebody creating something very meaningful to them, an artistic expression, is that where you've often seen students bring some of what they're struggling with forward? Is it there or is it elsewhere?
We talk about it, and I'll just get into it briefly, that we caution students about when they're dealing with something really deep in their art to edit and to just be aware of what's happening. So we have to slow the process down so they don't start to get really upset about things while they're trying to create. But it's, again, not all instructors or new art instructors don't know this. And so we try and put the information out there because it is a bit of a factor. Most of the people want to come and just draw trees and landscapes, but there are people who want to express themselves a little bit deeper as well.
Okay, other questions?
Can we maybe go to an online question or two?
Ethan, fire some off, please.
And I'm gonna put it up on the.
People unaware, Ethan and Eric are two of the people that help make this whole space happen, so thank you to you and.
Can you read that?
Okay, I'm gonna give it a shot. I don't think I need these, all right. Dr. Laura Armstrong with us, nice to see you here, Dr. Armstrong, psychologist professor. Does the city see the role of prevention of youth mental illness as part of the plan, rather than only reaching young people when they have high needs? For example, my team has a mental health promotion program that enhances both internalizing and externalizing mental health. This program reaches children before mental health concerns are more likely to emerge in adolescence. It was predominantly designed pre-pandemic in collaboration with all 4 school board mental health teams, over 200 children, parents, teachers, and a youth mental health advisory committee. This program can be implemented by anyone, teachers, coaches, community leaders, because it uses brief video teaching episodes to go along with original music and hands-on games, crafts, and drama activities. Would there be a role for a program like that to ultimately reduce the likelihood of youth mental illness? I guess this is, we could pose this question to Cindy and to Sherry. When you were thinking about your catchment of partners in one call, one click, Dr. Armstrong's proposing something there during this. Is the umbrella always being cast out? Like, who's doing this work? How does help?
Yeah, I think we attempted to try and get an idea of, like, to actually understand what everyone is doing in the area is really tricky. What we did realize is there's a lot going on. And so we endeavored to create a calendar on our website that encaptured anything that's going on in the community that's related to youth, mental health, addictions, or substance use health in the region. And we're going to put it all on our website. And we put it all on and we were like, it was just so many different things. And we're just like, oh, walk-in clinic here and an art therapy class here and this here and OT sessions. And so we ended up just trying to have to use filters because there was so much. So trying to encapsulate everything that's going on, there's a lot of amazing work going on that people don't know about. Right. So that's where I always say when people say to us, oh, would you want to refer people to us? I'm like, careful what you wish for. We get a lot of, we've reached over 10,000 young people since we launched just 2 years ago.
Right.
So I think that's a big piece, right? People knowing the services that are going on. I mean, Anchor, we work closely with, so they're always giving us all the events that they're holding for families, and we encapsulate those on our website. And our intake workers all know about it, so they can offer them to families when they're talking to families. So it's really important I think that's a piece. I'm not sure we totally have it all yet, but just really trying to pull people in to say, what are you offering in Cornwall? What are you offering in Renfrew? Like through the whole region of the Champlain, what would have been formerly Champlain, to kind of say, so that we can send people where services are.
We now call it Ontario Health East. And it's big, and Dr. Armstrong, expect an email from us. We'll make sure you're part of our report. Sherry, do you have any reaction?
I don't have much to add to what Cindy said. I think she handled that really well. I mean, I certainly think that any program that is going to address things at the outset is going to benefit youth. And when it's in formats that are easily digestible, easily disseminated, and they were proven effective by research, fantastic. Those should be implemented.
Right. All right. Yes.
Hi, I'm a pediatric school shift nurse.
Okay.
And I work for an agency, and I just want to know how come we don't get specialized training on like one click or anything going into the school and working one-on-one with kids. All these resources are kind of new to me this evening, and maybe reaching out to St. Elizabeth, to the agencies that go into Crucio to the schools, training their nurses on it. We can hand out those pamphlets, like you
Yeah,
said, print it
100%.
out and
Yeah,
do posters as well. You said you had 14 booths on the ground, but I'm sure there's lots of agency nurses that would be.
yeah, we've definitely, it's a good point, because we've definitely, the mental health and addictions nurses moved over to our program just September, not last year, the year before. And I think one thing that I put on our work plan for this year is to identify who else is going into schools. How do we work with those people, right? Like, because we are not the only person doing mental health in the school. And so building those partnerships to say, okay, what are you going to focus on? So as a nurse, you have a special skill set that's different than a counselor and that's different than a psychologist. And what are you looking at and how are you, making your little niche so that people are working together? And we've heard from Ottawa Public Health saying, we really do want to partner more and we want to talk about more about how we align our work plans. So we've just done a huge undertaking of moving our nurses over and getting them comfortable in the work with One Call, One Click, and now starting to kind of look at those partnerships and hoping those develop more as the school year starts next year.
Yeah, that would be great.
But yeah, I would love to get your contact.
Yeah.
All right, well, that question sounded a lot like what we wanted to do in the second half of the afternoon. It's all about networking, figuring out how we can work together and collaborate more, but we certainly have time for at least another question. Yeah, go ahead, David.
Hi, my name is David Julian Whiteman. I'm a support services worker at the Civic Hospital. Recently wrote an article sort of exposing some of this mismanagement that's happening within the hospital. And I wanted to speak directly to what it's like for folks who end up in the emergency department. Of course, the Civic is for sort of more adult age, but there's still people who end up there 16, 17 years old, 18, young people ending up in psych emerge. In the intake there, I'm not going to shock anybody, it's really bad. And this psych emerge itself, I would say, is one of the worst places that I've ever been inside. As a cleaner there, I experienced not necessarily seeing the worst of the worst, but hearing about it, and then also being in scenarios where I remember one of the nurses describing the unit as she's working on it, describing it as a jail. And we need to see that there is a carceral phenomenon happening in our, not just in an emergency department, but when they end up on the 6th floor as well. That we're having an experience of people being essentially locked up and punished for their mental health, for struggling with mental health. I've seen it over and over again. With me today as a parent of one of those residents on the unit, and people who are extremely struggling to get basic dignity. Not like it's care is there. I mean, the question of care is significant, but it's like some of these people are suffering in the sense that they're not receiving basic dignity when they end up in the hospital system. They're treated basically with punishment. And also I want to raise the issue of racism. I don't know if we've talked about that yet, but this is an issue when it comes to mental health that I've seen even in my position as a support service worker. I've seen it over and over again. This is one of the pointiest issues when it comes to mental health is the racism, the structural racism within the hospital, is that it's often at its worst when it comes to mental health.
Dave, thank you. Cindy, sure, did you have anything you wanted to say about waiver action? We're going to make sure, David, that this is something we talk about in the report. Appreciate what you're saying.
Yeah, if I could just add to the question. If I could just add to the intervention, it's also notable to say that like Black and Indigenous youth are disproportionately, affected by these services, and even when we have right, for example, training for an anti-racist mental health care, where we're trying to provide resources, a lot of the people in place are not willing to accept them or even implement them. I say that from experience, just because I'm a student and I've been, in these spaces where I was just like, I wasn't taken seriously, or the people who are supposed to help me or supposed to give me some kind of resources are not exactly doing their job. And I've had to go for myself and look for these myself when I was 17, 16, 18, right? Which is even like in my own school, I was the one who had to seek out a research lab in order to provide anti-racist care for students. And when I was trying to bring up the issue to the administrators, to my professors, and it was just like, majority of them were like empathetic, sympathetic, but not empathetic.
Right.
And, you know, it's kind of like, when we bring up these issues, how are we being heard? Like, what are you tangibly doing in order to help this, in order to reduce this discrepancy? Right?
Yeah.
Exactly, you know, just the act of intervention. And that's important, should be.
Appreciate
So, first of all, thank you for this. I think it's only through conversations like this that we actually are able to talk and share for things. So we have a child in a mental health situation, an addiction situation. And look, I don't want to use the soapbox, but we started off with family physicians. We moved to Youth Services Bureau. We did the trip with Rita Wood. We've been to Day Spent a few times. And from our experience, look, there is great intakes, right? Like you can get in, you can talk to people. You can get one quick off sessions, but you can't get long-term help. And so the only reason I get on my soapbox, because I know you're going to write a report on this, but if there's that gap, it's like getting access to the system wasn't the problem, right?
Right.
It was actually getting the help in the system that was the problem. And it's exactly as someone mentioned earlier on, it's like our child was in distress, having mental health issues, but he wasn't suicidal, not yet, eh? Yeah. And so, you know, things should go bad, they go really, really bad. You end up in SHIO, you end up in the emergency ward, you sit there for 10, 12 hours, and then eventually you go home because you're exhausted, right? And then 3 weeks later, you're back in SHIO, you're in the emergency ward again. You sit there for 10, 12 hours, you're exhausted, you eventually go home. There's just, the capacity is not there, right? And then the capacity as far as actually getting the long-term help. Fortunately, we've been able to get into the TAPE program at the Royal, which is fabulous as far as we can tell. We're relatively new in that world. But we are well-educated, reasonably affluent people that had access to pediatricians, that had access to services that could navigate the system. And I don't want to say we failed, but we're not exactly batting it out of the park either. And if we can't do that, how can the average person that's struggling just getting through the day do that? So look, I don't want to spend the time in the soapbox, but if there is a message to deliver, there is inadequate funding in the space. There's quick access to quick fixes. But if somebody has long-term mental health challenges, reasonably affluent people can't find them. So look, I guess that's all I have to say.
I appreciate you saying.
Yeah, and I heard a term when I was working, we were setting up this program and someone said, you know, one call, one click for those that are kind of on that higher need, or they're not, I'm not going to match the YSB and that's going to be enough. They're going to need maybe a few other things. And it sounds like very similar to what your situation is. And this PLEO person said to me, you need to make families feel like we're catching and holding them, like we've got them. And so I always get a little emotional, but because it does, like it's I got you, right? Like I got you if you need funding for, you know, respite, or if you need, you know, to figure it out a little more, you need someone to go to your house and figure it out with you. And so we embedded one, now she's an N of one, but we embedded care coordination within the one call, one click program, which is out of the coordinated access program in Ottawa. And it's basically exactly that idea of make you feel catch and hold. So you might have like 3 kids that are all struggling, and how do you navigate 3 kids to 3 different places and all this stuff. And it's that having this Michelle go to your house and be like, okay, what are we talking about here? Instead of me bouncing you to one place and then over to another place and over to another place, let's figure out where you need to go. What do you need? How do we get you there? And then if I don't know, we've actually started working with other coordinated access mechanisms within the region. So, you know, Cornwall and Renfrew and Prescott Russell, to kind of say, okay, so what do you have in your area that can catch and hold families if they're not from Ottawa? Because there is also that piece of those remote communities that don't have as many resources as there is available here in Ottawa. So I think that's an important piece to mention, but you're not wrong, right? Like, you're not wrong in saying, you know, navigating the system, and when the problem changes, it doesn't always look the same. And sometimes you go to emerge and you sit, and the crisis, by the time you're seeing the crisis is over, and they're kind of like, well, he's good now, like, you can go home. Yeah, so it is, and that's where that rotating door is, that we're trying to stop the rotating door and see where we can match. But agreed, everybody has a lot of people have a short-term modality, and the longer-term services, there's no longer.
And if I could add to that, oh, sorry, I just wanted to add and really acknowledge that there are some problems that really require long-term help.
Yeah.
I have people that I have worked with for 10 years when they've had complex, serious mental health difficulties, and I've taken them through adolescence and into having children, because they have needed that level of continuation of care. And there are virtually no public agencies that can have a mandate like that. So, you know, you are absolutely right. When you're dealing with someone with a substance use problem, it's going to take a lot of work over a long period of time. And currently, our system is not in a place where it acknowledges the need for long-term services. We have really changed to short-term models, and short-term models do not fit every problem. They're great for some problems and they're not great for others. And so I really want to acknowledge the pain of that, to sort of know what your child needs, and to be this really involved and really caring parent who loves your kid, who wants to see them well, and feels like what they need is not being met. And it's really painful and really, really difficult.
And then, like, I know I've already had my turn, but so it starts with mental health, and then in our case, it turned to addiction, right? But it was always a mental health issue. But when we started going to the services, they turned it very quickly into an addiction issue. Oh, if you just solve this addiction issue, everything would go away. But the mental health thing is there before, right? And that goes to my last point. It's just the omnipresence of drugs in society, in Glee, in your wards, it's astonishing how easy it is for kids to get access to drugs. Like again, relatively good parents, relatively informed parents, like, we've done everything, but there's no stopping it. Like if you want access to anything in downtown Ottawa, you can get it within an hour, maybe less. And I start with cannabis. Cannabis is super omnipresent, but
It starts with alcohol and tobacco use. Right?
Sure, yeah, agreed. And then, but it quickly goes beyond that. It should go on the report. Like, there is a serious problem, at least in Denver, probably in greater Ottawa, like.
We're starting through our office to hear more about gambling addictions too, particularly the online. Liz, you could.
Gaming addiction as well. Video gaming addiction, online addiction is another source of addiction that we really need to be paying attention to, especially post-pandemic.
So I'm Liz Hall. I work at the Royal in our early intervention program, which is a school-based program targeting primarily grade 7 and 8 students. It's a model where we meet with clients on a weekly basis for 30 to 50 groups over a 2-year period in grade 7 and 8. So although the program has existed in Ottawa for more than 30 years, even within the school systems where we're working, a lot of people have never heard of it. But at the same time, there's 3 of us for the whole city. So there's some real severe limitations of what we can do. We have schools on our waiting list. And I think, I really like the model. We work with the students over an extended period of time at an age where they're potentially really vulnerable, and mental health and potentially substance use issues are just beginning to emerge, and hopefully helping them develop the resiliency skills and emotional regulation skills and communication skills, conflict resolution skills, and all of those things that hopefully help them have a better path. And I think the main thing that I want to say is, at the end of the day, all of these are services that require resources. And, every dollar that you invest at a prevention level saves so much money later down the road, right? And it's just, it saddens me that we have this service, it exists, but it's so poorly resourced. The number of schools that we can offer the service to is very small.
Well, we're gonna have an opportunity after what you just said, Liz, to start advocating for you. I'm gonna thank everybody who came. I know it's always insufficient when you get into a deep conversation like this, but this is the beginning, right? So I want to thank Sherry, Cindy for being with us. But now is the opportunity for you to visit all the other friends we have in this room and check in. And it's we've got food that's been put out. Thank you, Erica, and thank you, Ethan, for making sure that that's out. And we've got opportunities to mix and mingle and learn from each other now. Okay, so we are going to, as I said, we are going to be doing a report coming out of this. We're going to make sure that the people who came here have a sense that it accurately reflects what you've said before it gets out to the wider world. But that's going to be an opportunity for you to share, network. If you've got a stake, everyone has a stake in mental health, not just for you, but for everyone. Let's promote it. Let's make sure we can get Ontario to be even more. Erica, did you have something you want to say?
Yeah, we just got so much to do.
We have so much.
People need
We need your help as well. All right. Thank you, Jared. Thank you for being with us.
Thank you, everybody.